Okay, everyone, welcome back. As I promised you, I'm going to do my best to try to wrap this up for you and then maybe have one more video for you, which would be a review of the whole chapter. We'll do the best we can. Just a reminder that I posted your movie assignments if you had them in on time. I think everyone scored 25. One person, you should see a 15. That means it was a day late. One didn't get an assignment, so 0. Uh, we were talking about juvenile delinquency on page 464 and the different level 454 and the different levels of juvenile delinquency. So be sure you can distinguish between the different levels. Now, there's going to be 4 different disorders between now and the end of the chapter that you're going to need to be familiar with. So now we're getting into a little bit of psychology, where if your background is not psychology, you may have a little bit of more difficulty, because to make a diagnosis, you have to have certain criteria. And so if a test question is just giving you a scenario about a kid engaging in some various behaviors, like I covered the other day in the last video of shoplifting or running away from home and some of those things that I referred to as status offenses and index offenses and so on, then that's what they're fishing for on the question. But at the end of it, if they give you some of those examples and they say, so-and-so might be diagnosed with, then the answer is going to be a specific mental disorder. And the reason I bring this up is because on the same page here, 454, you can see the term conduct disorder. You do need to understand what a conduct disorder is. And quite honestly, the author, he really just kind of scratches the surface here. It's a lot more involved than what is in the book. In the Diagnostic Statistical Manual of Mental Disorders, it probably takes a couple of pages to explain it. Here he does it in a few sentences. But for our purposes, we'll go with what it says in the book, and that is that you've established a persistent pattern of behavior in which you're violating the rights of other people. So a persistent pattern of behavior means it's been going on for some time, and you have to have multiple offenses. So in other words, you can't get a diagnosis of conduct disorder just because your kid went in on the weekend and got in trouble. That does not establish a pattern of behavior. And so technically the pattern of behavior is in the past year of multiple offenses, 3 or more, with at least one having occurred in the past 6 months. The author doesn't explain it very well like that, but that's really what it is. But for our purposes, you just look for multiple offenses, and it could be from any of the 3 categories I gave you in the last video. They could all come from they could all be status offenses. They could all be index offenses. It could come one from each of the 3 different levels of delinquent behavior. It doesn't really matter. Just assume that it's multiple, and that's 3 or more. And it's been going on for some time, 6 months or more in this case, and that the person is a juvenile. We'll say 15 years or younger. So it's not about the adult population. That's a different diagnosis. So please keep that in mind. So if you have any questions, probably the best thing is to send me a little email or whatever you do, and I'll try to clarify for you. But if you can just kind of keep that basic criteria, you'll be okay. On page 455, there's some antecedents to juvenile delinquency, and I'm going to get those in just a second. I'm looking at the next PowerPoint under statistics, and basically all I want you to pick up on there is a couple of things. One is that there's far more juvenile delinquency than there are adjudicated delinquents, and all that means is to be adjudicated, you have to be caught and then found guilty. So kids are doing lots of things that they never get caught for. So when you see 10%, they're talking about kids who are getting caught. That's what's actually showing up in the courts. The other thing that's important on that page, it says 80% of that is made up of males, juvenile males. So that ought to tell you that males are far more likely to be adjudicated delinquent than are females. And so in the system, in the state facilities and group homes, they're predominantly male. And so males get the diagnosis of conduct disorder far more common than do females. The antecedents, I'm not even sure I have a PowerPoint for it, but I think I've covered everything. But look at figure 7 on 456, and they give you the antecedents. For instance, authority. In other words, having trouble with authority figures. These kids, high degree. They struggle with submitting to someone's authority. Covert and overt. Covert is sneaking around doing things, and overt is right in your face, out, aggressive. Their identity, when you see negative identity, what they're talking about, they literally wear their juvenile delinquent behavior as a badge of honor. So they might even tattoo themselves showing that they've been in a facility, almost like someone coming out of prison. It's like among their peers, they think that's something to be held in high esteem and looked up to. High degree of distortion I talked about in the biological cycle, the biopsychosocial model. When you have distorted thinking, you justify irrational or maladaptive behavior, and that's what these people are doing. They lack self-control. The earlier the initiation, the worse. Males are more likely. I'm going right down the list. Peer influence is going to be high, especially in this negative peer influence. Socioeconomic status. Typically, kids come from poverty. There's more opportunity to get in trouble and so on. Neighborhood quality, again, the poor neighborhoods lead to more problems. So those are all antecedents, or things that certainly put these kids at higher risk than other kids. Well, we're moving into now toward the end of the chapter, and so I'm over on page 459, depression and suicide. So one of the first things you're going to need to know is a second diagnosis or mental disorder, and that's major depressive disorder. Major depressive disorder is typically a chemical imbalance in the brain in which obviously a person has experienced a depressed mood for some period of time. So be very careful with this. To diagnose a person with major depressive disorder, they must have at least 5 of the 9 symptoms you see listed here on this page. They have to be experiencing those symptoms consistently for at least a minimum of 14 days, 2 weeks. There cannot be a break in there. So for 14 straight days, 5 or more of the symptoms listed, and you will get a diagnosis of major depressive disorder. If there's a break in the mood, then it becomes bipolar disorder. And so as far as prevalence rate or by gender, where juvenile delinquency, I told you, is going to be predominantly males. Under major depressive disorder, more often than not, it's going to be females. So keep that in mind. As far as how to treat it, 2 things really, and it's usually combined, they work together. One is a prescription medication, an antidepressant of some sort. You put them on a regimen of antidepressants, and you get them into counseling or cognitive behavioral counseling or therapy to work with these clients. Now, another possible question under this depression diagnosis section is, well, why females more likely than males? And so if you go down to about the 3rd paragraph in the bottom of the page, it's going to list a number of things. It could be anything, but more likely with females, they tend to ruminate or think about things over and over, and that can lead to depression. Discrimination, puberty. We talked about mixed feelings going through puberty and body image and so on. So if you read it, there's about 4 or 5 things that they specifically point out that females may experience more often than do males when it comes to depression. Now, the next page, 460, is going to list a lot of other things that are possibly going on. It's just things that any of us could experience. Because you have to remember with depression, it can be due to a chemical imbalance in the brain, which means there doesn't have to be anything that you're experiencing to lead to the depression. It's just the way you are. It's biological. But then the next page goes on to other things which are more social issues, like dysfunctional families, kids who feel isolated, socially incompetent, no friends, trauma, things that have happened in their life, their overall condition of their life. So there's any number of things that could be leading to that. The next screen that I'm looking at here is suicide. And the number one thing that I want you to pick up here right off the bat, since we're kind of discussing depression and we're discussing suicide, is that when it comes to a correlation of 2 factors that are highly related to one another, the number one or the strongest correlation that you're going to look at is depression correlated to suicide. So a person who is experiencing depression is at much higher risk. It's one of the risk factors for suicide, so keep that in mind. It's very rare among children. It starts to increase in late adolescence, but the highest risk, according to the author, as far as just the age or developmental stage, is the emerging adult population. It's a serious risk group, and it says, according to the text, that group is 3 times more likely to commit suicide than are adolescents. So childhood rare, late adolescence starts to increase, emerging adults, the rate triples. Now the suicide rate since the 1950s has tripled. But the book will tell you recently there's been a slight decrease in the number of suicides among the adolescent population, mostly because we pay more attention to it, we take it more seriously, and so on. We're more familiar with the signs that we're looking for, and so on. By gender, if you have to pick who's more likely to attempt suicide. So I guess I should back up here for a second and make sure we have some terms cleared up for you. You have people who have suicidal ideation. That's not an attempt, that's just they've thought about it. Then you have people who attempt suicide, but they don't actually commit suicide or complete suicide. They don't like to use the word commit anymore, but complete suicide. And then you have people who actually commit the act or complete the act of suicide. So when it comes to attempted suicides, females are far more often more likely to attempt suicide, but not complete it. The reason is for that, and be sure you make a note, is because of the methods they use. They take a much more passive approach than do males, and by that I mean they may overdose. They may cut their wrist. In either case, intervention is possible. You can get help and they can recover. With males, males are far more likely, 3 to 4 times more likely as far as a rate of suicide, actual suicide or completing suicide, far more often than are females. And that's because they take a more direct, or active is the word you're looking for, meaning much more aggressive. So they're going to use something like a weapon, like a gun, leap off of a high structure like a building or a bridge, or drive a vehicle at a high speed into an immovable object like a concrete wall. In other words, there's no time for intervention, and it's more than not likely going to end up in death. Another possible question that you could face on the test regarding suicide is culture or ethnicity. And what they find in America, there's 2 ethnic groups in particular that are high risk. One is the American Indian population living in isolation on some of these reservations where there's a lot of poverty and high alcoholism. The other group is the Native Alaskan population, where they're also isolated and alcoholism. So those things are common. So those are two of your higher likely groups as far as ethnicity goes, or cultural. Some terminology on this next PowerPoint I'm looking at: early and recent, or distal and proximal. Distal, when it says early, what they mean is early in life, years ago. So a person may experience distal suicidal ideation or attempts, meaning something could occur years ago, they've never resolved it, and now they've just decided the only out they have is to attempt suicide or commit suicide. Proximal means recent. So if you're asked, this scenario would be more like something that's just occurred within the past 12 months, like a breakup in a relationship, the loss of a loved one, followed by a suicide attempt. So proximal means recent, something that you could look back and say, well, I know a few months ago this happened. But the distal, most of the time people don't even realize what's going on, because it may have never been revealed. The figure 10, this is just for your purposes to help you what to do, what not to do. I'm going to keep it simple. What to do means get help. If you even suspect someone's at risk, it depends on your profession. And some of you are going to be teachers, for instance. You're gonna have to be a mandated reporter. You're going to have to report any suspected attempt of suicide, or even that you just think a person might be at risk. It's your responsibility. In fact, it's the law. Basically, what not to do is don't ignore it. Just because you don't have a PhD in clinical psychology doesn't mean you shouldn't still report it to someone and try to get help for that person. So don't just ignore it because you don't feel comfortable bringing it up or discussing it, with a young person. I wish we had more time and I'd discuss this more with you, but I'm trying hard to finish this for you. The eating disorders, I'm going to move on and try to wrap this up. Eating disorders. There's 3 eating disorders listed. Used to only be 2. Now they have it divided into 3. The first one is the most serious, and that's the anorexia nervosa. Basically, the disorder here is a relentless pursuit of being thin. These people never stop thinking about losing weight somewhere. They can always see somewhere where they need to lose some additional weight. It's the most serious of all the eating disorders and can lead to death. Mostly all of the eating disorders, the prevalence rate is going to be female. Far more often females are going to be diagnosed with eating disorders than are males. The criteria has been changed, but again, these books are published, and so the information is outdated, but most recently they have changed the criteria, but we'll stick with the criteria in the book because that's how the test question is going to be written, obviously. But basically, the person has to have a weight that is 85% of what would be a normal body weight. So an easy example, let's just say a young girl, average weight for her size would be 100 pounds, teenage girl. If she weighs less than 85 pounds, and she should weigh 100, then that meets one of the criteria. They've dropped that, but because it's very difficult to determine what would be normal weight for a person. But for right now, that's what we'll go with. Second, an intense fear, almost to the point of a phobia. It's just irrational that they have a fear of losing weight. They know exactly how many calories they've taken in, and they're going to burn that many calories to lose it, to make sure they don't gain any weight. And so that's the second criteria. And the third is a distorted body image, which that's also a different diagnosis in itself. The only difference is in body dysmorphia, you maybe think your nose is too big or your ears are too big, but for this purposes, you just feel like you have excess weight when in reality you don't. And so what you see as excessive weight, other people are looking and don't understand what you're looking at. And by the way, it's very rare, even in females, you're talking less than 2% of the population. It's a very, very small number. The other two eating disorders, the first one is called bulimia, and now they call it bulimia purging. What that simply means is the person eats a lot. They indulge, they go to a buffet and they just eat and eat and eat. They overeat, but then when they go home, they will purge one or two ways, either forcing themselves to vomit or taking some sort of laxative, and they purge their system, and it's a cycle repeated. And then the final one is just simply bulimia, non-purging, where a person's eating is just an eating disorder in which they're out of control. There's no purging involved, and so they're overeating for reasons of emotional distress or other things like that. It's a comfort to them, and so on. You'll find all of the information that I've just covered on 466 and 467. I'm looking at the chapter from that point on. There's just a couple of pages left. I don't see anything there that I'm going to be asking you about. So I feel like I've covered everything. I'm looking at the key terms on page 473. In the first column, I've just covered anorexia nervosa, binge eating disorder, the biopsychosocial approach, and bulimia nervosa. So be sure you know those terms. In the second column, be sure you know conduct disorder, the depressants, which I covered with you, and developmental psychopathology. In the third column, externalizing problems, hallucinogenics, index offenses, internalizing problems, and juvenile delinquency. And in the final column, major depressive disorder, status offense, stimulants. So those are your key terms. On the next page, 474, I don't really see any names that you need to concern yourself with memorizing anybody's name associated with anything, so don't worry about that. So I'm going to stop this, and in the next video I'll do a review with you, a real quick overview.